Hello everyone! Welcome back to my YouTube channel, the MCL Charge Capture and Coding.
Welcome!
Hello everyone! We are at the last leg of our lecture series on abscess drainage procedures. I wanted to thank all of you for learning with me from the beginning up to today's presentation. We are going to talk about the surgical excision of abscess drainage procedure from a billing and coding perspective. Full disclosure, the main sources of my lectures are the CMS website and our current CPT 2024 codebook. I will mention my other online resources, if there are any, as we go along with our presentation. Please feel free to pause the video if you need more time to read through the descriptions and information shown in your screen, and hit the play button when you are ready to resume with our lecture presentation. So, let us begin. Let us first do a quick recap from our previously concluded parts 1, 2, and 3 video lecture presentations. First, what is an abscess? An abscess is a collection of pus surrounded by a wall of tissue. It causes a painful lump and can make you feel unwell. An abscess happens when your body tries to control infection by forming a wall around an infected area. Pus forms within this wall. As the amount of pus increases, the lump grows and causes pain. You can get an abscess anywhere on your body. We have learned that people with weakened immune systems are most vulnerable to have skin abscess. This means that these people have decreased ability to ward off infections, such as chronic steroid therapy, diabetes, AIDS, peripheral vascular disorders, ulcerative colitis, severe trauma, obesity, chemotherapy, cancer, sickle cell disease, Crohn's disease, severe burns, alcoholism, or IV drug abuse. In short, severe abscess most often occurs in people who have weakened immune system. Four abscess drainage modalities are included in our 4-part video lecture series. In our Part 1 lecture, I presented the incision and drainage procedure. In our Part 2 lecture, you learned about the needle aspiration procedure. Through our Part 3 lecture, we talked about the catheter drainage procedure. Today, now our Part 4 lecture presentation, you will learn all about the surgical excision procedure on an abscess. Note that incision and drainage procedure is the most common type of abscess drainage. So, if you can remember from our Part 1 video lecture presentations, we have these following codes. Again, append a modifier when applicable for hand or finger, foot, or toe. If you can recall from our Part 2 video lecture, we discussed about a patient who has a peritonsillar abscess, that sometimes the physician would treat it with a combination of incision and drainage and the needle aspiration procedures. The following are the codes we talked about in our Part 2 video lecture presentation. Feel free to pause the video if you think you need more time to read them through. Simply click back on the play button to resume with the presentation. A common procedure in most radiology practices is the utilization of a drain or catheter percutaneously under an imaging guidance. This is what we learned from our Part 3 video lecture presentation. Most often, the development of an abscess, regardless of its location in the body, requires further intervention when a simple incision and drainage, even needle aspiration, cannot be performed. Now let us recall the codes we talked about in our Part 3 video lecture presentation. Again, remember that procedure codes may be subject to National Correct Coding Initiative or NCCI edits or OPS packaging edits. Refer to NCCI and OPS requirements prior to billing Medicare. BUs 10060, 10061, and 10160 CPT procedure codes for incision and drainage of pus-producing paronychia without ingrown nail. We use 11750, 11765 for permanent correction of recurring ingrown toenail procedure. For treatment of paronychia with nail avulsion procedure, we report 11730 and 11732. And please do append a modifier when applicable if the procedure was performed on the hand or the finger, or the foot or the toe. One thing to take note of is that if an abscess is simple, antibiotics may work, but will not be as effective in most cases. Sometimes, draining the pus with a needle can help, but the pus may come back. It depends on the extensiveness and how complex the abscess is. Both physicians and patients usually thoroughly weigh in the pros and cons of the situation, the alternatives, and the recommendations prior to finally deciding which route is better for the patient to take. If surgical intervention is preferred, the healthcare provider would inform the patient of the benefits of the surgery, one of which is that the patient should no longer have the abscess and be relieved of pain. Surgery is the best way to prevent the occurrence of serious complications that an abscess can cause. These are the documentation requirements according to the LCD reference article A57044 found in the cms.gov website. The benign lesion excision procedures, reporting CPT code 11400 to 11446, must have medical record documentation as to why an excisional removal, other than for cosmetic purposes, was the surgical procedure of choice. Excision is defined as full thickness through the dermis, removal of a lesion, including margins, and includes simple or non-layered closure when performed. Each benign lesion excised should be reported separately. Also, please remember that code selection is determined by measuring the greatest clinical diameter of the apparent lesion plus that margin required for complete excision. That means lesion diameter plus the narrowest margins required equals the excised diameter. The margins refer to the narrowest margin required to adequately excise the lesion based on the physician's judgment. The measurement of lesion plus margin is made prior to excision. The following ICD-10-CM codes belong to Group 3 codes and are therefore considered applicable as secondary diagnosis to Group 2 codes when billing and coding for removal of benign skin lesions. This means that a primary diagnosis code from any of the Group 2 codes and any of the secondary codes you see in your screen now that represent a complication are required. Please refer to CMS LCD reference article A57044 for a complete list of Group 2 and Group 3 codes. General complications of any operation are as follows: allergic reaction to the equipment, materials or medication, bleeding, blood clot in your leg, in your lung, etc., or a chest infection. However, the abscess may keep coming back, may be slow to healing if your wound was packed. In some cases, some complications can be serious and can even cause death. Talk about how the surgical incision works. A small abscess can be drained under a local anesthetic, although in most cases the physician would need to provide the patient a general anesthetic. The operation usually takes 20 minutes or even less, but in other cases may take longer. Your surgeon will make a cut on your skin over the abscess. This allows the pus to drain out. Once the pus has been removed, the cavity needs to heal upwards from the inside out, so the opening in your skin is left open. If the cavity is deep, your surgeon will place a pack called antiseptic dressing in it to keep it open, allowing pus to drain out and your wound to heal properly. Some known consequences of this procedure are pain and unsightly scarring of your skin. Billers and coders, we decipher whether the following codes are applicable depending on the progress notes of our physician. Please note that all these procedure codes are about treating an abscess. Please note that you can use CPT code 55100 if you are reporting a drainage of the scrotal wall abscess. If the abscess is of the epididymis, testis, and/or scrotal space, report CPT code 54700. The incision and drainage of epididymis, testis, and/or scrotal space, such as for abscess or hematoma, because this code is used to report procedures to any of the 3 areas. Codes 55720 and 55725 are used for reporting prostatotomy. 55720 for simple and 55725 for complicated. The prostatomy procedure is that which involves making an incision into the prostate gland to drain an abscess. Our code selection is based on whether the procedure was simple or complicated, as documented by our provider. A complicated prostatotomy would involve excess bleeding or other factors that service. For transurethral drainage, use 52700 CPT code. Transurethral unroofing is an effective approach to the treatment of prostate abscesses and is a minimally invasive surgical procedure. This technique should be considered for abscesses that are large and multiloculated, and in those that have recurred post-needle aspiration. You can check more information about this procedure through the link of the website shown in your screen. For the surgical excision of a type 1 intersphincteric supraelevator abscess, report CPT code 45020. This code is appropriate for draining abscesses in deep cavities such as the supraelevator, retrorectal space, or pelvirectal cavity. Please refer to Figure C for correct internal drainage of the abscess with an intersphincteric septum. Please refer to Figure D for an alternative internal drainage in continuity with an internal sphincterotomy that demonstrated an anterolateral type 2 extrasphincteric abscesses. These are drained external via ischioanal fossa with or without a transsphincteric septum through the primary fistulous trajectory. For more information, please see the online reference link shown in your screen. So that is it for our Part 2 video lecture presentation on needle aspiration procedure. Up next is our Part 3 video lecture on catheter drainage procedure. We will talk about this procedure in detail along with its billing and coding guidelines, as well as the documentation requirements published by the CMS.